Alright guys, seminar's starting.
Cool. Hi everyone. For anyone who doesn't know me, I'm Maya. I do medicine and I like talking about medicine and I like debating about medicine. But often when I debate about medicine, people say a lot of lies and that makes me really sad. So I'm going to give this seminar and hopefully you guys will learn some fun facts about medicine that you can use in debates and not say any lies. Yay. Okay, so I'm first going to talk about research.
You want to use the mic so that it's recording better.
But the recording is just on a phone, right?
Yeah, so I'm sure it'll pick
be fine, but mic.
Okay, sure. So first I'll talk about research because I think this is the most common type of medicine debate that comes up, but also you can run an extension on medical research in a debate that's generally about research. I think it's useful. So, a few things. The main message about research is it usually doesn't work, it's sad-based. Most medications that are developed fail at some point in their testing, so only a very small amount actually ever become real medications. Why is that? So if you want to develop a drug, first you have to have like a concept, so you have to understand the disease and the drug, and then you have to test it on animals, then you test it on people who are like healthy and well, and then you test it on people who are sick that you want to like see if it works. So basically you're testing like animal testing is pretty obvious, then you're testing does it cause any side effects, and then you're testing does it actually work to solve the problem that we want to solve. Why do these drugs usually fail? Because you need to prove that it's better than drugs that already exist, which is quite hard because obviously people have already spent a lot of time developing drugs. So most of the drugs that we have are pretty good. So you have to prove that your drug is like better, which is difficult to do. But also most drugs have unexpected side effects. And in particular, once you get to this point of testing it on sick people, you usually get side effects because obviously they're sick, so they've got other stuff going on. Or if they're like say an older person, they might have a lot of they might be taking other medications, they might have other like issues going on. So often you get unexpected side effects that can be bad enough to like not let you continue the drug. And also obviously animals are pretty different to humans, so often it doesn't work out how you expected when you test it on people. So this means that the majority of drugs that are tested actually fail. And that also means that it's super expensive to develop a drug because not only do you have to pay for the cost of manufacturing it and the cost of researching it, you also have to like pay people to be in those trials. And in order for your drug to be trustworthy, you need really big trials with like thousands of people. And I don't know if you guys have ever seen this, but you can actually like sign up to be in a trial if you want. They usually pay you like $1,000 a day. So they're giving people like a lot of money to convince them to do trials. And then you also have to pay like for both stages of trials. So it's super expensive. And that's why medication is really expensive because essentially the company is trying to like offset all of the money and time they put into research, but they're also trying to offset all the money they put into the drugs that failed, like the drugs that they spent a lot of money researching but didn't actually work. So that's how they try to make a profit. It also means that it takes a really long time to develop a drug. So if you because to go through all those stages, you want to see if your drug has long-term side effects, right? Which means that often it takes like 10 years or so to actually get to the point of selling it on the market, which means it takes a really long time for you to get profits from a drug. So that makes it extra expensive because you have to have enough money to kind of keep yourself afloat for that 10 years until you can start profiting off it. Another important thing to characterize in terms of drugs is what type of drugs are usually developed by pharmaceutical companies. And this is like drugs that will kind of treat you but not cure you because it's like, I guess, more profitable to have someone buy your medication for the rest of their life instead of having them actually be cured and then not need to buy your medication anymore. And also pharmaceutical companies mostly make variations on relatively common conditions. For example, high blood pressure. There's about 50 medications that treat high blood pressure and they all are very similar in effectiveness. Like they're not that different. They have slightly different side effects, but that's kind of like a guaranteed market that you can access. So it's profitable to do that instead of making something that treats a very rare condition that affects like 1 in 1,000 people because then you won't be able to sell it to as many people. And also it's mostly problems in the developed world because in low-income countries, people and governments can't afford to spend lots of money on medication, which means you don't have as many customers there, so you don't make medication for tropical diseases and stuff like that. And yeah, because they need to justify the cost of producing it. Which is why it is important to have government and non-government organisation funding in order to fund research to fix those incentive issues and fund other types of medications. But that's a lot of grim things about medical research, but there are a lot of exciting drugs being developed at the moment. It's not all pessimistic, I promise. Those are just some cool new things that are being developed. So there's like a whole new class of drugs called biologic agents, which is without doing too much technical detail. It's basically like proteins that like treat diseases. And that's like a very new thing that's happened in the last 10 years. And it's being used to treat like cancer, autoimmune stuff. So not all sad in the pharmaceutical industry, but there are a lot of things that you can characterize as to the issues and how it works currently. Does anyone have any questions on those few slides? Does that make sense? Cool, okay. The next thing to talk about then is, because obviously researching drugs is a type of research that most often gets talked about in debates. There's a lot of other types of medical research. So the most research, and this is true for all sciences, not just medicine, most research that exists is literature reviews or meta-analysis. This is where you're analysing research that other people have done. For instance, like you want to know, say if you want to know it's like better to treat something with like antibiotics or surgery, you'll go and you look at like 30 studies that have looked at that, and then you'll combine all their results and be like, 20 of these studies said antibiotics are better and 10 said surgery is better, so therefore antibiotics are better, or whatever. So you're reviewing data that already exists, and literature reviews are like similar, you're just kind of summarizing the data. These are common because they're very cheap to do, because you don't have to run an experiment, you don't need subjects or trials or anything, and as an academic you want to publish as much as possible, so it's an easy way to publish something for very low cost, like you don't need a big grant for it or anything. And they're like a bit useful, but I don't know, they're not that useful, personally. I think that you're kind of just, you know, the research already exists, but it is obviously important to like analyze research that exists, but that is the majority of research that happens. There's also research to determine if something is a risk factor. So for example, you can like follow people up who vape to see if they develop lung cancer in 20 years, or you could retrospectively like look at a bunch of people who have lung cancer and measure how many of them vape to see if vaping is a risk for lung cancer. But those take a very long time because you have to wait 10 years to see if lung cancer develops, or maybe 20 years or 30 years. So they're also quite expensive to do. And you can also do epidemiology, which means measuring how common a disease is, which is important for getting like public health data. You can also test public health interventions, and you can also just do general sort of scientific research about the basis of disease. Those ones are less common that come from debates. This pyramid shows like the different quality of all these types of research. So doing a meta-analysis is like the highest quality because you're analysing other research that's been done. Randomized controlled trials is basically what they use to test drugs. So that's when you have 30 people that you give your drug and 30 people that you give a placebo, and you measure their outcomes and see which one is better, and it's randomized which group they're in. The middle two ones, cohort studies and case control, is this stuff about determining if something's going to be a risk factor. So it's not as accurate as a randomized control trial, but it would be a bit unethical to be like, okay, 30 people, you guys have to vape for 10 years, we're going to see if you get lung cancer, and 30 people, you guys aren't allowed to vape. So obviously you can't do randomization there, so you would do like just following up the choices that people have already made. So yeah, that's a little bit about research in general. All right, so this is an example topic about research, that we should grant those diagnosed with terminal illnesses the right to access treatments that have not completed clinical testing. This is a little bit of a, comes up often. Can anyone give me some arguments for this on affirmative? Yes, thank you.
The possibility that it could be cured, or that
Yes.
the condition could get better, because there's so much speculation there.
Exactly, so they could get a cure. Anything else? Yes, you know.
Get wide-scale testing.
Yep, so it's good for the research, like the research of that drug is accelerated because more people are testing it. Yeah.
And plus they're already going to die, so it's like instantly trying to justify.
Yes, the hopelessness argument. I love it. All right, what about arguments on opposition? Anyone and think yes?
This could make their condition actively worse.
Yeah. Yeah.
Like ability to consent. Like
Yeah.
the fact that you know you're gonna die might like steer you over.
Yep, absolutely. I forgot to write that, but that's so true. There's a very interesting principle clash there. But yeah, it can make your condition worse. And can we think of how we might prove on opposition that it's more likely to make your condition worse than make it better? Yeah.
Because again, speculation, you can flip the speculation to say that firstly, I'm assuming it would be drugs that are related to the terminal illness that they have in most instances, otherwise it's a bit, yeah, there's just speculation as to this hasn't been done, this hasn't been gone through the complete clinical testing phase, so it could just definitely harm you.
Yeah, absolutely. And the main thing that I want to get at here is this is where you would use all of that analysis about why most drugs fail. So, I mean, yeah, so government, you'd say like freedom of choice, you don't have any other options useful for research. But the opposition case, which I like a bit more, is that you can prove that the medication is likely to fail, given that most medications don't make it through testing, and this is a medication that's still in testing, which means that firstly, it probably won't work, so it probably won't cure you of your disease. And at best, because this is kind of, unfortunately, the types of, for instance, treatments that we develop for cancer are usually treatments that might extend your life by 6 months or 9 months. So we're realistically not talking about a cure, we're talking about extending your life a little bit, and it will probably have a lot of side effects, because all the things we said, like at this point, maybe it's only been tested in healthy people, and then now they're testing it on you, who's a sick person, who's got a lot of other stuff going on. So it's likely to cause a lot of side effects, which could really quite drastically reduce your quality of life. And those side effects are very hard to predict, because as someone who's very sick, you're probably on a lot of other medications as well. And then, yeah, I guess just as another little note, you could already, if you wanted to, you can like choose to enroll in trials in the status quo, but you'd be enrolling in a medication that was already like at the stage of being tested on sick people, and they have more like criteria for who can be in those trials and stuff like that to make it sort of more fair. So yeah, that's the sort of arguments for that debate. Yes, question.
Can we prove that, maybe it's written, there, or maybe not. But can you prove that we would not get important medical data on the treatments? Probably because this person is at the terminal end, has a terminal disease, has a very limited amount of time left. So maybe that affects data in the trial. What if they die early on, or what if they have different forms of medication that they're taking? And it's not just about this drug then, but it's also about how this drug interacts with like their chemo regimen, for example.
Yeah, exactly, 100%. Because especially you could say because often maybe this new drug is going to be good at helping people in the early stages of the illness, but if this person's at the point where they're desperate, they're probably in the later stages. So it's kind of unlikely that maybe the drug would help someone who's at the early stages, but they're not going to help someone who's at the late stage of the disease. So therefore you might falsely think, oh, this drug doesn't work, it doesn't do anything. But actually, if you follow the normal trial process and you tested it on someone who's early in the disease, isn't taking lots of other medications, has less complications, you might have actually proven a benefit. So they could just be the wrong candidate for it. Yeah.
So I guess in terms of medications that fail, I'm just wondering what percentage fail due to the fact they have active harmful side effects, and what percentage fail just because they don't impact the condition. Because I guess if you're taking a medication that doesn't have side effects but doesn't fix your condition, there isn't really a harm there.
That's true. I mean, I don't know what the data on the percentages is, but it kind of fails like most fail at the animal trial stage, and then the next most fail at the testing on healthy people, and then the next most, it kind of fails less as you go up the pyramid. But basically it's because I think that a lot of the time you can sort of predict side effects in animals, but it's a bit harder to predict effectiveness in animals because they're a bit different. So I think it's sort of a lot of the time, maybe you might get through testing it on healthy people without crazy side effects, but then you get to testing it on sick people and you realize actually, because they've got all this other stuff going on, it actually doesn't really, it only improves their condition marginally, and it has a couple extra side effects, so it's not really worth it. Because, and you also have to justify not only that it helps them a little bit, but you also have to sell it to governments, you have to sell it to the Australian government to convince them to put it on the PBS or the American equivalent and stuff. So if governments don't think it's much of an improvement, they won't subsidise it, and then people won't buy it. So you also have to, I guess, show a significant improvement, which is hard to do. All right, any other questions on this debate? Cool, all right, another example. This is an example from ABPDC, if anyone was there. This house regrets the merging of pharmaceutical companies into extremely large firms, and the little info slide they gave was a lot of pharmaceutical companies merged in the 1990s. A lot of this debate is sort of economics-y arguments, but there are a few interesting medical research arguments we can make. So what would be the arguments on government? They're mostly sort of economic ones, but anyone got anything? Yeah.
Price gouging, because you have the biggest share of the market.
Yeah, exactly. So forming monopolies and therefore making it super expensive to buy medications.
If you have big monopolies, then it's unlikely that they would invest in research of drugs that are super out there or super innovative, or about diseases that are not well researched because it isn't profitable and there's no competition against them.
Yeah, 100%. So they can just kind of keep on relying on their own patents. They don't have to be innovative. Competition is good for innovation. Yeah.
Regulation.
Yeah. Yeah, 100%. So they can get around regulation. They can lobby governments. They can avoid lawsuits because they can hire better lawyers. All of that sort of stuff. For example, I think in America they've done a lot of lobbying to stop the price of insulin being capped, which makes it very expensive for people to buy insulin. So they do unfortunately have a lot of lobbying power, and obviously we all know about the opioid crisis and how that was also influenced by the ability of pharmaceutical companies to do a lot of lobbying. What about opposition arguments? Because this debate, I think, seems on face value like a pretty good idea, but I think there's some pretty decent opposition arguments. Yeah.
Well, the cost of research is very high, and smaller companies might not necessarily have the capital to fund it.
Yeah, absolutely, and yeah.
Large companies can do more risky stuff, but it's not get less higher.
Yeah, 100%. So it's what we were saying, of if you're a small company, you probably have to fall back on making another high blood pressure medication because you know you'll be able to sell that to someone. But if you're Pfizer and you're really massive, then you can probably afford making something risky like a malaria vaccine that might fail, but might get you a lot of money into the future because you can kind of make that. Yeah, so basic government arguments are monopolies makes it bad, less competition is bad, regulation and legal stuff. Opposition. I think you can do the fun little, especially because they gave you the context and they merged in the 1990s. You can always do the fun like, well, obviously they merged for a good reason, and be like they were probably gonna I guess go bankrupt if they didn't merge. But specifically, you say all this stuff about why, because medical research is so expensive. You need to have enough scale to do it. But I guess the fun sort of extension form of that is that when you have that sort of security, it allows you to research more interesting things and more risky medications, which is really important in getting more medications to places like the developing world. And you can try, I don't know, the regulations clash in this debate is a bit messy, but you can try and prove that it's easier to regulate one big bad person instead of lots of little bad people. But anyway, not here to talk about regulation. All right, cool. So that is research. Next thing is to talk about what these sort of problems are with the healthcare system in the status quo, because this is the other kind of debates that come up. So first is problems that affect everyone, and then second I'll do like problems that affect like specific groups at a disadvantage. So cost is pretty bad. These are mostly Australia specific. There's not Australia specific ones later. Cost is pretty bad. It's difficult to find bulk billing, as I'm sure we're all aware. Most GPs don't do it anymore, but also if you want a specialist, then they never do bulk billing, so that's bad. Private versus the public system. I think there's, in a lot of the world, the private system means you can access much better care. That's not necessarily true in Australia. The quality of care between private and public systems is actually very similar, because the way that it usually works is that doctors work in both. So you might do like 2 days in the hospital and then like 3 days in your private practice, or like 2 days in the private hospital, 3 days in the public hospital. So most doctors, so you actually kind of have the same doctors, whichever system you're working in. The main advantage is that in the private system, it's much shorter wait times, which is good. For instance, if you want to get a surgery, you have to wait a very long time, like often up to a year to get a public. Yeah.
Sorry, but I don't understand what bulk billing is. I keep reading it, but I just don't fucking know what it is. I keep seeing it everywhere, and I know it's good to have bulk billing.
Excellent question. So when something is fully bulk billed, that means it's basically free. So bulk billing means that the GP practice like charges Medicare instead. So Medicare will pay them to treat you. So if you have a bulk billing practice, you get appointments for free. But most places these days will have Medicare, say your appointment costs like $120. Medicare might cover like $60 and you have to pay $60. But bulk billing means free healthcare in the Australian context.
That's interesting.
It used to exist. It doesn't really exist anymore, and that is because Medicare doesn't give GPs very much. So they kind of have to charge you a little bit in order to like make money. Yeah.
I have private healthcare insurance, just saying, because I'm not a citizen of this country.
So
but I get bulk billed.
Slay.
So
I get bulk billed because I'm a medical
So
student.
it does exist if you're.
Yeah,
You pay
right.
a lot of money.
If you're rich, then you get free healthcare, basically.
Yes, there is also health insurance, which I guess sort of counts as a private system, which covers some stuff. Maybe my insurance is just bad, it just doesn't cover very much stuff, but it does cover some stuff, which is useful. I get free dentist appointments. But yeah, so most doctors work in both. The other big issue in Australia and all over the world is the nursing shortage. So you might have all seen the massive new emergency department they opened in Prince of Wales. If you ever go to Upper Campus, it's very big, it looks very cool, but they can't use it properly because they don't have enough nurses to nurse all the beds. So there's not very many nurses because nurses don't get paid very well and have to work really long hours. And it's the same for other allied health, so like physios, pharmacists, stuff like that. They're very important, they do very long degrees, they have a lot of the same knowledge as doctors, they don't get respected enough. There's lots of issues, so there's the obesity epidemic, people aren't exercising enough, there's a mental health epidemic, lots of stuff going wrong. Another big issue is the shortage of general care, so it's more expensive because they don't do bulk billing, and also there's often really long wait times and you get really short appointments, so you might only get like 7 minutes, which is not enough time to do a proper consult, so that's also not good. And general health, so GPs are really important. Here's my medical advice to you all, tip one is to all make sure you have a GP, they're really useful. But when we have good GPs, that means that we can prevent diseases earlier, which means people don't have to be hospitalized, which is far more expensive because it costs a lot of money to keep someone in the hospital. So GPs matter. All right, let's talk about the aging population because this is a big issue. So most developed countries in the world currently have aging populations. Old people are the majority of people in hospital by far, and old people all have very similar medical issues. So there's often kind of a triad of having diabetes, high blood pressure, and high cholesterol, which gives you blood clots, which gives you strokes and heart attacks, which are obviously very bad conditions. And this can be prevented at the first step. This can be prevented by treating diabetes and high blood pressure and high cholesterol, but often that doesn't happen because people don't see their GPs and stuff like that. These are preventable. So that's the first big issue for older people, is they've got very similar diseases, but they all end up in hospital. Polypharmacy means older people are often on a lot of medications, like 10 or 12, and those medications cause side effects, and then you prescribe another medication to treat the side effects, and then that has side effects, and then it just kind of spirals. It's really bad. Another big issue is falls and osteoporosis. So old people have more brittle bones. They fall over, they break a bone. If you break your hip, 1/3 of people who break their hip will go back to normal, 1/3 will have to go to a nursing home, and 1/3 will die. So falling over is very bad for an old person. It's not good. Delirium happens when you get an infection, and then you just kind of like go, yeah, you get a bit delirious, you have to go to hospital, and cognitive declines, obviously like dementia and stuff like that. So a lot of very specific problems that affect old people. A lot of these can be treated and prevented, but they aren't done so very well. If you all have grandparents, tell them to get bone scans. It's important to check your bone health. But another big issue in older people is social isolation and mental health. So something that a lot of people don't realize, if I asked you guys what age group do you think has the highest rate of suicide, most people would say young men, like 20 to 25. It's actually old men, like 85 plus. And people don't realize because they're kind of, obviously have a lot of other medical issues, so it kind of gets hidden in the statistics. But it's actually a big issue because a lot of people get isolated, they have a bit of cognitive decline, and their mental health gets worse. And that's a generation that's not very willing to sort of get help for these things. And there's also, obviously, we all know the drama about the aged care facilities, how they did a big review, lots of bad things going on there. But the really important message at the end of the slide is that aging does not have to be a bad thing. Aging can be very, like, a positive and a fun experience. There is a very big difference between someone who is 72 and has diabetes, high cholesterol, has a heart attack, has a stroke, ends up in hospital, not able to move, versus someone who's 95, still lives at home, still sees their family, is happy, and then gets maybe like a chest infection and dies peacefully. Those are very different pictures. Obviously everyone dies at some point, but you can be happy and healthy up until you die, or you can have all of these things sort of going wrong. So aging does not have to be bad. Is that a question? Yes.
I was just wondering if if that statement, aging is not always bad, is a biased thing because of your affinity towards geriatrics.
Yes, I know. I feel, this is why the slide is really long. I feel so strongly about this. There is genuinely, like, being on the geriatrics ward, there are patients that, like, there was someone who was like an opera singer, and she was just like, she was lived at home, she could still do opera singing, she was like 95, she was having a great time. There's people who like have their whole family around them, and there's people who have are a lot less happy, have a lot more stuff going on. So like aging is obviously there are some things that are a bit inevitable, like you're gonna walk a bit slower, like, but all of these sorts of really bad conditions like stroke, dementia, that doesn't happen to everyone, and they are at least a little bit preventable. So aging does not have to be bad. Yes.
I watched an episode of Grey's Anatomy where they were talking about STIs in old age homes and how they're quite rampant.
They are, because one of the lesser known features of dementia is that you lose your inhibitions, so people actually often, get after it in aged care homes, and as they should, fair enough. But yeah, so STIs do spread. Okay, yeah, aging population. But yeah, I think this is kind of like, a lot of people have a conception of hospitals, because obviously we all watch like Grey's Anatomy and all those shows. We have a conception of hospitals as full of like 30-year-olds with like really random neurological seizures and stuff. But realistically, it's like literally half the people in hospital are just older people who've had a heart attack. It's very, very common. But yes, healthy aging is achievable. It doesn't have to be bad. Here is some data. So this is just to provide a picture. So the graph shows like ED presentations, like emergency. So you can see it's high in kids because kids have random stuff go wrong, and then it's lower, and then it's highest in the older age group. But also this data is about hospitalizations. So per 1,000 people, there was 981 to 1,469. That's over 1,000 because you can get hospitalized multiple times, and that was over a 2-year period. So that's most people. So that's like on average, everyone's getting hospitalized over a 2-year period, and that's 3 to 10 times higher than people under 65. So they are like the majority of people in hospital by a significant margin. Is that a question, or is that just bad? Okay, fair enough. Some other data. This is about the major causes of death in the world. I think this is also useful to have as a bit of perspective. So this first graph is like global. So the biggest thing is ischemic heart disease, which is basically the thing I was telling you. So like high blood pressure, clots, heart attack. COVID's on there because it's in 2021. Stroke, obviously also caused by the same thing. Chronic obstructive pulmonary disease is smoking. And then obviously we can see lung cancer as well with smoking. All the pink stars are ones that are preventable. So obviously pulmonary disease and lung cancer are caused by smoking, so that can be prevented. Diabetes is number 8. The diabetes increases your risk of all the ones at the top, so that's also pretty bad. Point being, that's a lot of stars. A lot of the big causes of death are preventable things that we can stop early. And you can see that they're all increasing. So the pale dots are like I think 20 years ago, like 2000. So since then, like all of the heart attacks, strokes, all of that has been increasing. The middle one is low income countries, so you can see it's a bit of a different picture. There's a lot more, so all of the blue ones are infections, so there's a lot more infections because there's a lot worse healthcare and a lot worse treatment. So for instance, like tuberculosis, diarrhea in kids, malaria, all of those are big issues. Lower respiratory infections is like pneumonia, but still stroke, heart attack are also big problems. And then high income countries, you can see again, basically all sort of the same preventable stuff. Heart disease, cancers, yeah. So that's just a bit of perspective. Most issues in the world are caused by the same set of problems. Yeah, check your blood pressure when you get old. So here's an example. This is a topic that I did 2 nights ago at Zagreb. This house would deprioritize state funding for the treatment, research and care of illness and disease associated with the effects of aging in favor of rare conditions that are present at birth. So I think we can probably all tell which side of this I think is much better, but there are some good arguments you can do on government. Crazily enough, on the motion statistics, this was actually it was government, it was biased towards government. I think it's crazy. But anyways, there are like a couple good arguments on government. Can anyone think of them? Yes.
Wait, so pretty deep. So I think like government funding is unique to this. Like let's say like aging population has other factors to fund it, whereas like rare conditions don't.
Yeah, absolutely. I think that's the most important gov argument is that like there's already sort of the pharmaceutical companies want to make things that will help old people because that's a really big market, but they don't want to make things for rare conditions at birth because that's a very small market. So then the government needs to step in and fund those rare conditions. Yeah.
A lot of the things like health outcomes are associated with aging and illness are the person's own doing, whereas rare conditions at birth people don't consent to.
Yeah, absolutely. So it's like lottery of birth, it's unfair if you get born with like a disability or something, we should try and fix that. Yeah, I think those are the main government arguments. What about opposition arguments? Yeah.
It's like net real estate funding increases because it's
Yeah, exactly. So it's like, I guess on scale of benefit, you're just benefiting more people. Any other ideas on opposition? Yeah.
Probably more likely to succeed because there's been more research done before.
Yeah, exactly. So if we think back to all the stuff I was saying about research before, you need big sample sizes to do research. It's quite hard to get big sample sizes of someone with a rare condition, right? And also they're a baby, so it's hard to like do research on them. Whereas you've got like literally millions of old people that you can test. So it's much easier to test your drugs, and they're more likely to be effective because you're kind of only solving one thing. That's the sort of core of it, but a few other ideas. So yeah, government, rare conditions don't usually get research, so government funding is important. And also, like, you can say there's a really big possible benefit because if you cure that person, you can give them like a healthy life forever. Arguments on opposition, it's more efficient and easier to research old people, which means your money is used better. Because if you like because it costs the same amount to develop a drug, right? No matter how many people use that drug, it might cost like $100,000. So if you're researching like a drug for like stroke, then that's $100,000 that benefits like 1 million people. But if you spend that $100,000 doing a drug that only helps some like a condition that affects 1 in every like 2,000 people, that's going to have a much smaller benefit. But then there's also some really interesting, you can explain why rare genetic conditions very likely can't be cured, because this is a bit of a biological argument, but if you have a genetic condition, that's like in all of your genes in your whole body, right? So you can't like take that out. Like as of yet, we can't do gene editing. So you can't like fix every single cell in your body, take that gene out of every single cell. Versus if you're an old person, you have a problem with your heart, we can fix your heart, like we can give you a surgery. So it's very difficult to actually cure these conditions. So realistically, the research is quite unlikely to succeed. And also all the common childhood conditions, we've already done a lot of research on them because, you know, people care about kids, people want to give them lives and stuff like that. So all the common stuff like cystic fibrosis already has pretty good treatments, scale of benefit. But also if you prevent disease, because the diseases in older people can be prevented, right? Like diseases like heart attack and stroke can be prevented. And if you do that, that means you're actually saving yourself a lot of money because then that person doesn't get hospitalized later, which costs the government lots of money. So you save that money that you can use for other stuff and also important for quality of life. And then there's a really fun principle, I think, that you can say that for a child that's born with like a really rare condition that gives them some sort of disability, they never really knew what it was like to not have that. Like they've only ever had that their whole life. But if you're an older person who's slowly losing functions that you used to have, you're losing the ability to walk, you're like losing your like mental ability, you knew what it was like to be like normal and healthy. So it's kind of like, it's worse when you lose that function. So it's better to like help that person regain the function they once had. And also there's a lot of reasons why, even though these diseases are preventable, like even though there's obviously lifestyle factors going into things like obesity and heart attacks. Often those correlate with like socioeconomic background. Like it's obviously quite difficult to get exercise if you come from a like lower SES background and stuff like that. So we can say it's not actually really their fault. And there is also genetic components. Cool. Any questions about this debate? I feel strongly about this. If anyone can't tell, I think it's important to look after old people. Anyway, yes, I was mad. It's okay. Cool. All right, let's talk about some specific disadvantaged groups now. Firstly, women. Everyone, make sure you know what this is. Make sure you know how to pronounce it. Please don't pronounce it wrong in this debate. It's very important. It affects 1 in 10 women. That's a very, very high percentage. Most diseases don't affect that many people. It causes super, super painful periods. Like it's the same pain as like breaking a bone. It's really bad. But the crazy thing about endometriosis is that on average it takes you 10 years to get diagnosed. That's like crazy. Like think about any other disease. 10 years is such a long time of like having all these symptoms, and the reason for that is that the only way you can diagnose it is by doing a surgery, which is pretty crazy. Like that's a big thing to undergo if you're not sure if it actually is going to be endometriosis or not. But also the treatment, I mean the treatment is okay for endometriosis specifically, but in general for women's conditions there are worse treatments, and there are a lot of unexpected side effects from medication. This is because when they do research they never use women in trials, or historically at least, and that's because there was a risk the woman could be pregnant. So they thought, we can't give any women medications in case they're pregnant, in case it hurts the baby that they might have. So that means that often they test medications on women and they realize, oh, actually this has a lot of side effects, which is bad. Also, there's not very good pain management. For example, getting an IUD inserted, very common procedure, usually done just like totally awake, not under any sedative, incredibly painful. I personally think that if men got this procedure as well, it would definitely be done under general anesthetic. So lots of issues, and a lot of that comes from there's not as much incentive to like research women's health. So that's why endometriosis has such a poor that's why it takes so long to diagnose, because just no one's ever researched a blood test that might diagnose endometriosis, which is pretty sad. But it is getting better. They have developed a medication that might treat endometriosis. That is a good thing, but yeah. Next group is queer people. So in Australia, it is getting easier to access hormones because your GP can prescribe them, which is pretty good. But obviously in the rest of the world, particularly in the UK, this is quite bad. But it is very difficult to access surgery. It's very expensive. You have to wait for a very long time. There's one other good thing in Australia is it's getting much easier to treat HIV, which is obviously not only a problem for queer people, but there's like free testing, free treatment, stuff like that, which is really good. But there's still lots of issues with access to surgery, and in the rest of the world, this is obviously still a very big problem. Obviously, I can only talk about that so much. You should go talk to some townspeople about it. Then lastly, rural people. So it is very difficult to access a GP in rural Australia. Often it takes like 3 months just to get a GP appointment, which is pretty bad because if you've got something going on like right now, 3 months is a long time to have to deal with that. And also obviously like geographical distances, it's hard to get to a hospital or specialist. And then the next one is First Nations people in Australia. There's a lot of historic mistrust of health systems because health systems often perpetrated a lot of the colonialism and really bad things that Australia did in the past. So people are rightfully often quite scared of going into a hospital. One way that this is being improved is by Aboriginal healthcare workers who are basically Aboriginal people who work in hospitals and like liaise between the patient and the doctor, which is really good. There are also a lot of really specific diseases in rural communities. For example, scabies, this is like a crazy, this is a bit of an anecdote, but I think it's really interesting, and I think it is a bit telling of how poor like outcomes are for rural care, particularly in Indigenous communities in Australia. Scabies is a little mite that kind of like infects your skin, and it gives you like it makes it really itchy, and it's quite unpleasant. There is a little bit of it in cities, but it's pretty uncommon and it usually gets treated pretty quickly. But in the Northern Territory, people get scabies and they scratch at their scabies and that causes a skin infection. And that skin infection can then, if you get like a specific bacteria causing that infection, that can then give you rheumatic fever, which gives you rheumatic heart disease, and then you have heart problems for the rest of your life. And because no one intervenes in that like series of like outcomes, that really bad outcome of heart disease comes from a really minor condition of like scabies, which is a skin infection, and no one kind of like steps in and breaks that chain, which is really bad. And trachoma is also like an issue that causes blindness, like a parasite that causes blindness. It's very uncommon in cities, but happens in rural areas. So that is obviously quite not good. But it's important to remember that obviously there are a lot of issues for Aboriginal people living rurally, but the majority of Aboriginal people do live in cities like Sydney. So I guess just like not all Aboriginal people live rurally, but people in cities also have other issues. The bottom one is culturally and linguistically diverse people, so like immigrants, people who don't speak English. Obviously this makes it harder to access health systems because you need translators, which you can't always access, and it might be harder to get culturally sensitive services. Often people might not trust healthcare as much. And lastly is people with a disability. Often doctors aren't very good at kind of understanding disabilities, and often particularly people who have, say, intellectual disabilities, issues can be missed because they might not be as good as communicating that, and doctors kind of might ignore whatever symptom they're having, and then that can become a bigger problem. Does anyone have any questions from those two slides? No? Okay, I think that's medicine internationally. So this is some issues around the world. So tropical diseases are not very well researched, so that's like things that affect, so a lot of the world is tropical, so like Southeast Asia, the Caribbean, all those places, and a lot of Africa. A lot of diseases affecting those places aren't researched very well, so obviously like malaria and dengue, but also a lot of the sort of more niche ones too, like specific parasites. Because there isn't a market for pharmaceutical companies to do it, and because governments can't afford to pay for medications, which is quite unfortunate. And also tropical diseases are spreading because of climate change. More of the world is becoming tropical. There's a lot of staff shortages in more low-income countries because people aren't as able to access university, so you can't train as many people to be doctors and health professionals. But also there's brain drain. People might go overseas to train to be a doctor, and then they might not come back to their original country, which means that you can have shortages of doctors. It's quite hard. A lot of medications need to be kept cold, like vaccines. So just logistically, it's very difficult to get medications and treatments to communities that live more remotely. And it's very expensive to access healthcare. Usually the government doesn't subsidize it as much as it does in countries like Australia. And there's a lot of physical barriers, so often there's quite poor services for people who live rurally. So all of this is just to remember, this could often be an extension in debates, just remember that other countries have worse healthcare systems than we do. Yeah. Cool. Oh, and childhood mortality as well is also a big issue in a lot of lower income countries from a lot of preventable infections, like that slide I was showing before. I think that's the end. Oh yeah, general principles, if in a debate, it's a medicine debate and you're stuck, just ask yourself these questions. Ask yourself, what are the incentives of pharmaceutical companies? Is the medication going to be effective? Is there going to be side effects? Who's going to be able to access the medication? Is it going to be really expensive? Is it only going to be accessed by the developed world? What problem in the healthcare system is this motion trying to address? What specific people, what are the stakeholders, all that, and how is this going to impact the developing world is usually also a good thing to think about. Okay, does anyone have any questions? Questions, fun facts, yeah?
What's your thoughts on palliative care?
Oh my gosh, okay, yes, this is another good topic to talk about. So, palliative care is a very important part of medicine, and I think most people believe that palliative care is what happens in the last day of your life. They come and they give you lots of opioids and then you pass away. But actually good palliative care should start months or even a year before you're actually going to die. So palliative care doctors work really closely with people who have any form of terminal illness, even if it's not imminent, and they actually can do a really good job of making it much more peaceful. For instance, they can give you lots of very effective painkillers. They're basically just experts at making you really comfortable. I think palliative care is really great. Obviously, that's not to say that things like voluntary assisted dying should be allowed. I think that's a part of palliative care. I think people should be allowed to make that decision if they want. But yeah, countries like Australia are pretty good at providing people with good palliative care. But in other countries around the world, there's a lot of fear about using opioids. People think, opioids addictive, opioid crisis. They think oh, it's going to make the person die faster, but that isn't true. So there's a lot of fear about using opioids, but actually they're very safe and they're very effective in making people happier when they are dying. But yes, and I guess the fun fact about voluntary assisted dying, while we're talking about it in New South Wales, the way that works is you have to ask for it to 2 different doctors on 2 different occasions, and then if you've asked for it separately, and obviously both those times it's unprompted, the doctor can't ask you if you want it, you have to voluntarily suggest that you want this thing, then you're allowed to access it, but there's sort of a lot of limitations. So for instance, I'm on placement at St Vincent's and they don't offer it because they are a Catholic hospital, but you can access it at all public hospitals now, which is good. Yeah.
What conditions can you access assisted dying?
Basically it's anyone who is terminally ill and has capacity still can access it. There's not specific conditions that you can do it for. Obviously a big one would be cancer. I think that for doctors to approve it, they have to believe that you're in the last few months of your life, so it can't be significantly before. But yeah, another fun fact about the legislation is that because of the specific way the law is worded, you're not allowed to call if you you can only have conversations with patients in person. If you email them and talk about even if you just mention voluntary assisted dying, that's technically illegal because of the way that it's written. I don't know, it's weird. Anyway, it's still a very new area in this society. Yeah.
I believe Canada was considering including mental illnesses as one of the things that you get euthanasia for. Thoughts, feelings?
Ooh, that is an interesting one.
Crazy.
No, it's I mean, I think that like I feel like I think it's one of the cases where I think that this would be a very bad idea in like 99% of the cases of people who have mental illness, because people do get better, and often when you have a mental illness that's like particularly severe, like say like schizophrenia, psychosis, you don't realize that you're going to get better, but you know you will get better and people can tell you that. But I suppose that I would probably, well, I don't know what my thought is, but I imagine that if it's being like decided on by like psychiatrists, I guess I would kind of trust them. Like I'm sure that there's a very minority of cases where people genuinely do have really severe mental illnesses that aren't going to get better and is really impacting their quality of life. And I believe that if a psychiatrist like approved that, maybe that would be a right decision. So I think, yeah, that would be my thought. I trust other people to make that decision, I suppose, but most of the time it's bad.
There's documented issues like people having difficulty accessing mental health care.
I don't know about like the actual research on it, but I'm definitely sure that would be true. I mean, in Australia at least, I mean, you can get like a mental health care plan, which is cheap, but then obviously getting a psychologist is expensive, so it's pretty high. And I assume in the developing world it would be even more expensive, with probably even less psychologists available, because there's, you know, a lot of cultural people. So I imagine, and yeah, I'm sure there would be more expensive.
And then she got
Cool. That's exactly so much.
Yeah.
So unless anyone else has any questions, we'll this debate now.
Oh wait, no, I didn't know I had this. I didn't know it because you're like emails and JSS.
Cheers.